So, welcome back. We have already discussed about the various side effects of anti-TB drugs, and now I welcome you to discuss about the management of the adverse effects of the anti-TB drugs. So, how do we manage the adverse effects of anti-TB drugs? So, let us see what are the general principles in the management of adverse effects of anti-TB drugs. First, you should check the dose of the medicine. See, many times the patient's weight may be only around 40 or 30 and he may be receiving pyrazinamide of 1500 milligram. So, it is very imperative that the dose of these medicines should be checked and we should see that it is appropriate to the patient's body weight. Then other causes of the symptoms should be excluded. For example, a patient having a seizures, it may be due to a CNS tuberculosis, it may not necessarily be due to tuberculosis, it may be not necessarily be due to the side effect of the drugs. So, we should always exclude what are the other causes for a patient having symptoms. Similarly, for hepatitis it can be due to any viral hepatitis or it can be due to other drugs other than the TB medicines which the patient is taking. So, all these things should be considered while managing the adverse drug effect of tuberculosis. And the seriousness of the adverse effect should be estimated. For example, many patients can have minor side effects like nausea or vomiting. So, it is not something for which a regimen needs to be changed. You have to counsel the patients properly, you have to give a proper diet advice, and if you add antacids or medicines for the gastritis, this problem can be managed. Similarly, skin rashes, it can be managed with minimum antihistaminics or so. There are very few side effects which are really warranting a change in regimens like thrombocytopenia and renal failure with rifampicin. If this is documented and if you are sure that it is due to these drugs, then we can consider a change of regimen. The adverse effects and its outcome should be documented. So, we have this treatment card which we will be showing later. In that we should always document what are the adverse effects, to which drug it is caused and how we manage. This should be recorded. And sometimes we may have to stop the drugs and we can introduce the drugs in a gradual manner. This usually we do it in cases of hepatitis. So, when a patient has a hepatitis after starting ATT, or if the patient is having a skin reaction, then we can introduce the drugs in a gradual manner. We can find out which is the offending agent and try to eliminate the offending agent and continue with the other drugs. The basic principle is that we should avoid the development of drug resistance. See, we should have regimens in which there should be at least 4 or 5 drugs which are effective, so that drug resistant tuberculosis does not develop in the first place. As you all know, prevention is always better than cure. Continuing the general principles, we should always have a symptom based approach. For example, you identify what is the symptom and you try to properly counsel or adjust the dose or give some added supportive care for the patient and have a symptom based approach to the drug's adverse reaction. So, you should classify the adverse reaction as minor or major, and if it is minor, you can continue the TB treatment and give symptomatic treatment like itching. For itching, you can just give antihistaminics and you can continue with the treatment. If it is major, if the like it is a way, like we have a Stevens-Johnson syndrome or we have a drug induced hepatitis, then you find out which is the responsible drug and either that drug or the entire regimen may have to be stopped, and you have to refer the patient to an appropriate specialist for management of the patient. And we have drug resistant TB committee in most of the institutions who are involved in the management and modification of regimens of MDR and XDR TB. So, they are always there to guide you on how to go about with such patients. So, let us see each symptom and how to manage these symptoms. So, the commonest symptoms with anti-tuberculosis drugs is, as we discussed time and again, 1/3 of the patients having GI symptoms like nausea and vomiting. So, most of these drugs can cause GI symptoms, and in second line in drug resistant TB medicines, the main drugs which are known to be associated with such symptoms are ethionamide, PAS, pyrazinamide and ethambutol. So, how do we manage these cases? Management, mainly it involves reassurance and counseling, and other options which we have are, we can ask the patients to embed the tablet in banana or you can ask them to drink less water or take the medicines over a long period. So, see, most of the patients whom we come across, the main problem is they get frightened after seeing the size of the tablets. Most of the time in TB medicines are too big, and when they see itself they start complaining to us that they are not able to swallow these medicines. So, these are some options which you can give them and you can motivate them to continue with the treatment. And you can administer the drugs 1 hour after antiemetics. You can avoid antacids, severe vomiting, you should monitor the hydration of the patients, and if it is ethionamide induced, you can administer it with milk or at bedtime. Vomiting is severe, you should withhold the drugs and investigate other causes like hepatitis. So, let us see how to manage a case of hepatitis during anti-tuberculosis treatment. So, as we always discussed, see, many of the symptoms may not be due to the TB treatment and it can be due to many of the associated illnesses. For example, hepatitis, it need not necessarily be due to anti-tuberculosis treatment. There are other factors which can cause hepatitis. So, when a patient complains of vomiting, the first thing which we should do is we should rule out other causes of hepatitis, like you have viral hepatitis, alcoholic hepatitis, amoebic liver abscess and hepatoma. So, investigation should be done for all these diseases, and these diseases should be eliminated before labeling that the patient's side effects are due to tuberculosis treatment. The common drugs which are usually associated with hepatitis during the treatment include pyrazinamide, isoniazid, rifampicin, ethionamide, para-aminosalicylic acid, cycloserine and clofazimine. So, how do we manage when a patient is having an abnormality in a liver function test? So, let us look at this flow chart. So, if the patients whenever a patient is complaining of vomiting or nausea or abdominal pain, you get an LFT done, and if the LFT, if the liver enzymes are less than 3 times the upper limit of normal, then you can just continue with the medicines. You can follow up the liver function test and for 2 weeks, for 2 months and then monthly. You can just, what he needs is just reassurance, and you can just continue with the regimen and you can just monitor the liver enzymes. Suppose the liver enzymes are 3 to 5 times the upper limit of normal, you have to see whether the patient is symptomatic or whether the patient is asymptomatic. So, if the patient is asymptomatic, you can just follow him up, you can just follow up and get a repeat LFT done after 2 weeks. Whereas, if the patient is symptomatic with a liver enzymes elevation of 3 to 5 times the upper limit of normal, then you definitely have to withhold the medicines, and till his liver enzymes settled, you can choose a non-hepatotoxic regimen like streptomycin and ethambutol, which is given till his liver function test returns to twice the upper limit of normal. And once the LFT is back to normal, then you can re-challenge and again monitor the LFT. Suppose even after re-challenge the patient persists and he still has deranged LFT, then you can consider a change in regimen. Next is, suppose the liver enzymes are more than 5 times the upper limit of normal, then there is no question, but you have to withhold the regimen. You withhold the regimen and wait till the liver function returns to twice the upper limit of normal. And once it is less than twice the upper limit of normal, if the patient is asymptomatic, you can reintroduce the drug and try to see whether he is able to tolerate it at that point of time. And suppose the patient is still symptomatic, then you have to restart as per the reintroduction protocol, which we will discuss. And other parameter which we have to see is the bilirubin. Suppose the bilirubin is more than 1.3, then you stop all the drugs and start a non-hepatotoxic regimen like streptomycin and ethambutol. So, let us see how to reintroduce ATT in such patients. So, if the liver function test is less than or twice the upper limit of normal, then first drug which we give is INH. We give INH for 3 days and then we add rifampicin for 3 days and then we add the other drugs one by one. So, while giving these drugs you have to monitor the LFT and look for whether the patient is having any symptoms. So, if the symptoms reappear, then you stop the drugs, and one drug which should always be reintroduced with caution is pyrazinamide. So, let us see the cutaneous and hypersensitivity reactions. Cutaneous reactions, the common cutaneous reactions which we encounter are rashes, pruritus, and rarely bullous skin eruptions, and hypersensitivity reactions like minor itching, rashes, toxic epidermal necrolysis, and exfoliative dermatitis. This is how you classify the skin manifestations, adverse effects of tuberculosis regimens. So, the drugs which are usually associated with the cutaneous and hypersensitivity reactions are ethambutol, pyrazinamide, rifampicin, and INH. And other in the second line, the drugs which can be associated with cutaneous manifestations include moxifloxacin, para-aminosalicylic acid, linezolid, and clofazimine. So, how do we manage these cutaneous and hypersensitivity reactions? So, if the reactions are minor, you treat with antihistaminics, that is if the skin rash is less than 10% of the body surface and there is no mucosal involvement, then you can just manage with antihistaminics. Whereas, if the rash is more than 10% of the body surface and the mucosal membranes are involved, then you should withhold all the drugs. And then what you do is you challenge the patient, you identify what is the offending drug, and you have to challenge with individual drugs. One by one you have to give the drugs. The order of reintroduction of these drugs will be, first you give rifampicin, see if the patient develops any side effects, then you give ethambutol, then you add INH, and lastly you add pyrazinamide. So, in this order the drugs have to be reintroduced. And if the patient is developing skin rashes to any of these drugs, then you discontinue the suspected agent and you substitute with injection streptomycin. Skin discoloration is usually very commonly noted with the use of clofazimine. So, next let us see how to manage convulsions in patients who are on ATT. So, the suspected drugs in patients who develop convulsions are isoniazid, cycloserine, and quinolone. So, these are the three drugs which generally can cause convulsions. But like we discussed earlier, so let us first rule out that these convulsions are not due to tuberculosis, and then if we still suspect it is due to the drugs, then we can make some changes in the protocol. So, how do we manage suspected convulsion due to anti-tuberculosis drugs? So, the first thing you do is you withhold the suspected agents and initiate anticonvulsant therapy like phenytoin or valproic acid in consultation with the consultant specialist, and you can increase the dose of pyridoxine to 200 milligrams per day, and you can resuspect the suspected agent at a lower dose, and if the regimen is not compromised, then you can discontinue the suspected agent. That is, if you have adequate number of drugs to treat the patient without using the suspected agent, you can discontinue that and continue with the regimen. So, anticonvulsants should be continued until the treatment is completed or until you withdraw the suspecting agent. So, let us see the management of common adverse effects of anti-TB drugs. So, the first common adverse effect is diarrhea. So, how do you manage diarrhea? It can be due to any of the anti-TB drugs. So, generally first we should rule out infective causes for diarrhea, and once having ruled out the infective causes, you can manage symptomatically with oral rehydration solution or just supportive care. The other adverse effects which is commonly noted is arthritis and arthralgia. This is usually due to pyrazinamide and quinolones. So, these are the two drugs which are generally associated with arthritis and arthralgia. Most of the time this is self-limiting and it disappears, but sometimes you may have to give minor NSAIDs like paracetamol or aspirin, and if it is very severe, then we have to consider change in the dose or stopping the drugs. So, the other side effect is peripheral neuropathy. Peripheral neuropathy is usually associated with isoniazid and other drug which is associated with linezolid. Rarely it can be due to ethambutol, PAS, quinolones, ethionamide, and cycloserine. So, what we do for this? We generally give pyridoxine 100 milligrams along with the ATT regimen, and sometimes we may have to increase the dose of pyridoxine to 200 milligrams per day. If it is still not manageable, then we can consider adding tricyclic antidepressants like amitriptyline and giving NSAIDs like paracetamol or aspirin to alleviate the symptoms, and we can continue the either we can continue the medicines at a lower dosage, or if it is still not manageable, we can discontinue the drug and plan for a switch off regimen. Let us see the other side effects of ATT. Optic neuritis. Optic neuritis is usually seen with ethambutol, though it is a very rare complication, and it can also be seen with PAS, ethionamide, clofazimine and linezolid. So, if it is documented that it is due to the offending agent, then we withdraw the agent and we refer to the specialist. Psychosis can be due to cycloserine, isoniazid, rifampicin, quinolones, clarithromycin and clofazimine. And again what we do, we withdraw the drug and refer to the specialist. Nephrotoxicity, it can be due to rifampicin. One dreaded complication of rifampicin is immune induced nephrotoxicity, and other drugs which can cause nephrotoxicity are aminoglycosides and linezolid. In all these cases, we withdraw the drug or we adjust the dose of the medicines. Thrombocytopenia can be due to rifampicin and quinolones, and we have to withdraw the drug. It is always prudent to involve the concerned specialist while these adverse effects develop, and you can discuss with them and manage these side effects. Hearing loss can be due to aminoglycosides, linezolid or clarithromycin. So, we have to document the hearing loss and compare with a baseline audiometry, increase frequency or lower the dose of the medicines, and discontinue the suspected agent if the regimen is not compromised. Hypothyroidism is associated with para-aminosalicylic acid, ethionamide and cycloserine, and if the TSH values are more than 10 international units per liter, we can start the patient on replacement therapy with levothyroxine. QT prolongation and cardiac arrhythmias are noted with quinolones, clofazimine, linezolid and clarithromycin. In such cases, you have to refer to the concerned specialist for management. Pseudomembranous colitis is seen with amoxicillin clavulanic acid, clarithromycin, imipenem celastin, linezolid, rifampicin and isoniazid. The management is vancomycin and metronidazole, and you have to refer to a specialist and consider withdrawing the offending agent. Gynecomastia can happen with rifampicin, INH and ethionamide. Most of the time it requires only reassurance, but if the manifestation is very severe, then you can consider withdrawing of the drug. Flu-like syndrome is noted with intermittent rifampicin administration, but generally what we do is we reduce the dose of rifampicin and we can switch over to a daily regimen. So, it is very important that we have to record the adverse effects of the drug. So, in the treatment card there is a column for noting the adverse effect. You have to see which is the offending agent, what are the reactions and how it has been managed. It has to be documented in the treatment register. So, let us now see what are the adverse effects of the new anti-TB drugs. So, all of you are aware of bedaquiline, which has been introduced lately, and dilaminid, which we are going to introduce very shortly, and it is very important that we know what are the side effects of these drugs too. So, bedaquiline, the common side effects which we encounter are mainly GI, which is very minor, like nausea, vomiting and diarrhea. Sometimes it can cause headache, dizziness, and one concern is QTc prolongation, especially when it is used in combination with other drugs. Other side effects are myalgia, arthralgia and hepatic increase in transaminases. Dilaminid is associated with nausea, vomiting, dizziness and QTc prolongation. So, what is pharmacovigilance? Pharmacovigilance is defined as the signs and activities relating to the detection, the assessment, the understanding and the prevention of adverse effects of any other drug related problem. So, the program of Pharmacovigilance has been set up by the Ministry of Health and Family Welfare from July 2010, and it is very mandatory that we all report and monitor what are the side effects which we encounter with anti-tuberculosis treatment. So, this is the form for reporting the suspected adverse reactions to for pharmacovigilance purposes. To summarize, anti-tuberculosis drugs can cause adverse effects. Adverse effects to anti-TB drugs have to be documented and reported. Prompt identification and management of drug adverse reactions is essential for the success of the treatment. Thank you.